Hi, good morning. I'd like to thank ICS for this opportunity. I work as a physiotherapist in women's health. Our trial evaluated the efficiency of transperineal trigger point dry needling as a treatment for non-cyclical chronic pelvic pain. Dry needling is an intramuscular treatment technique where a fine filament needle is used to target the underlying trigger point directly. We analyzed 2 interventions, pre and post-treatment, with the intention to treat. We required a total of 82 participants to see a mean difference of 0.62 with an 80% power. The gynecology team referred the participants based on a criterion, and they were allocated into Group A for manual therapy and Group B for transperineal dry needling with manual therapy. Our primary objective was to see the number of treatment sessions required within the allocated 10 treatments to effect improvement. The session where the participant ceased treatment willingly due to resolution was considered the endpoint. We also analyzed the pain rating scale pre-treatment, post-10th treatment, or earlier at the endpoint. Secondary outcomes evaluated dyspareunia, musculoskeletal pain, and bladder pain with the IPPQ and the female sexual function index. 102 were allocated, and our final analysis was 39 for Group A and 40 for Group B. The demographics between the groups were similar, with more gynecology surgeries in Group B. In our endpoint analysis for primary outcome, Group A required a median of 8 treatments to report resolution, and Group B required a median of 5 to report resolution, with statistical significance for Group B on the Kaplan-Meier survival curve analysis. Our pain rating scale was significant for Group B with a 95% confidence interval of 1.3 to 2.9. Pre-treatment, both groups had an equal median of 8. Post-treatment, Group A had a median of 2 and Group B had a median of 1, with an IQR of 1 to 4 for Group A and 0 to 1 for Group B. In our secondary outcomes, pre-treatment, a below normal sexual function score was reported by 84% in Group A and 100% in Group B. Post-treatment, a normal sexual function score was reported by 44% in Group A and 58% in Group B. A normal sexual function score is 26.6. Anything above is showing off. A median range pre-treatment for Group A was 19.4, and post-treatment for Group A median was 26. Pre-treatment, Group B had a median of 15.4, and post-treatment was 27.4, and on analysis, significance was for Group B. Among our IPPQ variables, we found no between-group difference for bladder and menstrual cycle-related variables. However, our dyspareunia and musculoskeletal variables were similar to our primary objectives. In terms of strength and limitations, no adverse effects were reported. Our demographics between the both groups were similar. We require a larger power to analyze bladder and menstrual cycle variables. Group A participants were allocated among 3 physiotherapists in order to reduce any treatment bias, and our trial lacked the following, which was a long-term follow-up blinding and a placebo treatment group. In conclusion, Group B showed statistically significant reduction in pain rate and dyspareunia achieved with fewer treatments. However, with our within-group analysis, there was significance for both groups, indicating efficacy for the individual treatment groups for non-cyclical chronic pelvic pain. Thank you. Questions?
Thank you, Bill Gibson, Edmonton. I wonder if you can comment on your study design. You've used an A versus A plus B design, which is heavily criticised and is very, very prone to type 1 error.
Okay, so
why?
We divided them into 2 groups. They were allocated into 2 groups, 2 treatment groups. Group A was manual therapy and Group B was transperineal dry needling with manual therapy. Yeah. We were looking at clinical treatments that is used quite regularly in physiotherapy.
Yeah.
Because they were allocated by the administrative staff and we weren't able to do a randomization by a computer allocation, we basically labeled it as an open label trial.
Yeah. But so, the study design itself is very prone to type 1 error, isn't it?
I wouldn't know what to say because I got the outcomes were, the questionnaires were filled by the participants pre-treatment and post-treatment by themselves. So
yeah, but that's not the point I'm making. The point I'm making is if you compare a treatment to a treatment and another treatment, it's very difficult to get a negative trial.
Well,
I think your results need to be considered in that light, and you need a blinded RCT.
Yes, you would need a blinded RCT or you would need a placebo treatment group. However, it is quite difficult to establish an intravaginal placebo treatment group in physiotherapy.
It's probably also very difficult to blind needling.
Exactly,
You either are.
You wouldn't get the outcome you want then if you're going, because you're treating, you're analyzing by intention to treat.
Yes, please.
De Leeuw, Netherlands. I have a technical question. I've had some dry needling in my elbow, but I was wondering, how do you do dry needling transperineal?
So the anatomy is king here. You do need to know your anatomy well. We would divide the muscles into superficial and deep muscles. So superficial muscles can be targeted in supine and crook lying, modified crook lying. Deep muscles can be targeted by side lying and in prone. You need intravaginal palpation and distraction of the muscle to needle the muscles.
I always was under the impression that were very small needles.
No. I bought the needles for that. Yeah, I kind of thought that much. So we get needles. So your elbow muscle, what you would have needled would be brachioradialis, and you would use a 40 centimeter needle to needle. This is the length for puborectalis, which is about a 70 centimeter.
There you go.
Okay. Yeah. I bought the needle because I knew I would get that question. Yeah.
Question over there.
Audrey Smith, Ireland.
And again, just to confirm, there are different techniques of needling. So I get this question: you stick needles where? I have done this treatment for 10 years. So I would say that if you're doing a deep needling technique, unlike elbows and shoulders, we limit the pistoling needling with the deep needling to about 6 to 8 seconds per muscle.
Audrey Smith, Ireland, physio. What muscles did you needle? Did you needle specific muscles, or did you clinical reason?
Because the presentation of non-cyclical chronic pelvic pain in pelvic floor muscles can vary. You can have all muscles involved or only one or two muscles involved. This was very clinical and subjective. We would needle all the muscles, but it would be based on the clinical finding when we examined the patient.
Masa Nordqvist from Sweden. How did you perform the manual therapy?
So empirically manual therapy tend to be myofascial trigger point release or tender point release or massage. However, if you look at studies in terms of manual therapy for chronic pelvic pain, they have varied from dilators, distension of muscle, to myofascial tender point release. So we would have done myofascial release along with the distension or stretching of the muscle, and in some cases, because we had a broad spectrum group of people, so I would have had ladies who came with vaginismus, they would have needed dilators and to take home exercise program of dilators.
Thank you very much.
Thank you.
Dead on time.